And before I start, I thank one and all for this inaugural being done on online and also being the first one webinar for the academy. And I also wish everybody who has joined and made this happen. And being the first webinar, I'm privileged to have the first talk. I'm very happy about it. And secondly, my talk will be revolving around as more of a larger platform, meaning the triaging for cancer surgery. And as I understand that it cannot be totally different for minimal access as well. Minimal access triaging may be added a little more, but basically I am going to talk on triaging for cancer surgery in the COVID situation. With this small intro, let me share. Are you able to see my? Are you able to see my?
Yes, sir, we are seeing. Make it full screen.
Okay. Fine. See, basically, we have been talking about cancer treatment means we would talk about that host, tumor, and the treatment. For the first ever time, I feel that we have come to a fourth factor, which is an external factor, which makes us think a little more differently than the usual paradigm. Basically, we are talking about the triaging in the background of COVID-19, which has become an external one. The triage, which I have made it as a triangle, where we are talking about the host, tumor, and treatment. The COVID pandemic is a bigger circle, which I have shown. Or even I take over the other aspects for those of you who may be knowing bits and pieces. Why we are talking very specifically about the COVID-19 pandemic with respect to cancer surgery. Mainly, the study came from Wuhan University, which said where they did major surgeries at the beginning of their pandemic, post-operatively they were proved positive, in which the fatality jumped. They were a little worried. Although the regular pandemic, which has resulted in a fatality of 2%, in the people whom they have operated, it has jumped. On this background, I just saw what is happening to the other places where the COVID-19 pandemic mortality alone, without any intervention like surgery. It was around 2%, but it jumped to 15%, up to 15% as the age advanced. And in diabetic mellitus and COPD and cancer, it went up too. And typically in a cancer patient is going to be usually old with COPD or diabetic mellitus, and this the dilemma. The risk of death and morbidity from COVID-19 versus the magnitude of benefit of intended cancer treatment will help us now decide how to go. Waiting period, how long to wait? In the COVID-19, we were told to wait for some time in the beginning. Yes, we also waited, frankly. But how long to wait? And this COVID-19 is going to settle down? As I understand, no. I have come to a point where I have decided that we will have to learn to live with COVID, the virus, rather than fight with it and eradicate. Then only I will do surgery if we start. I think we'll never be able to start surgery. With this background, we'll quickly see what is happening around us. I've taken some of the guidelines from all these people: American Cancer Society, the College of Surgeons, National Cancer Grid, Surgical Stuff, Surgical Oncology, etc. There are some few publications also in this pandemic which I have referred to. But whatever the guidelines they have prompted, they have come out with, do they have a proof? If you ask me, the answer is no. We don't have a proof of this. And on what background these guidelines have been created, if you ask me? They have taken earlier SARS or Ebola as their basis. And some of the seniors or the experts were called to give their opinions. And those opinions have been formulated as guidelines after detailed discussion among them. That is how the guidelines have been framed till now. We have not tested it. That's what I am trying to say. We have not tested it. Then what is this called as? This is called as precautionary principle. When the human activities may lead to morally unacceptable harm that is scientifically plausible but uncertain, action shall be taken to avoid or diminish that harm. On this principle only, I feel most of them have done what is they are calling it as guidelines. We don't have approved which would have tested and then said we have done a phase 1 study, phase 2, phase 3. Such principles and no evidence-based medicine is here. This is only a precautionary principles on which they have done these guidelines according to my knowledge. But the best one to tell or quote would be Dr. John, who was a retired professor of clinical biology at CMC Vellore, went on everywhere, which I think is the right method as of today. Any patient coming to the hospital for any ailment has to be treated as though he is COVID-19 positive, even though he does not have a relevant history or risk factor. I think this is the bottom line with which we are going to take over completely the triaging part. Principles of triage, which came mainly from the St. Louis University, has made that these cancers we cannot postpone. We cannot postpone as we think that they are not emergency, but at the same time they are essentials, and that is where the whole thing started. The only underlining thing in this whole slide, which I borrowed from the only slide I borrowed from the NCG, is cancer surgery should be considered elective, but has to be considered as essential. It has to be considered as essential. With this background, what I was trying to do is I was trying to categorize them into A, B, C for my own purposes, which I have tried to do it in my university hospital, which we are following. We will take up discussion somewhere, we'll have to have a template. This is how we have classified. All the emergencies with respect to cancer has been categorized as category A. Near obstructed cases like GI, where stenting is not possible, where the cancers with high transfusion requirements because the background of blood bank support was not that well because there are no donors available. And the cancers with concern for local perforation and sepsis. Whatever I am trying to categorize as A, B, C, they are not inclusive or exhaustive. But please understand, it is only indicative. In the category B, again, I am trying to tell the category, the cancers after neoadjuvant treatment with no response at all. And we have completed NACT or NACTRT, but waiting for such a long time with partial response. Category C, where surgery may be delayed, wherein the slow growing, like basal cell cancer, or well-differentiated thyroid, or ductal carcinoma in situ, where alternate treatments are possible for time being if you are going to try to make them go to save some time, and the palliative surgery. I wantonly pushed the question mark on minimally invasive surgery for a simple reason. In the beginning of this pandemic, there are some contradicting reports coming, including SAGES saying that it is aerosol generating and hence it may be avoided. This is what the first statement came. Over 8 weeks time now, things are moved much better, and I am sure we are going to discuss in detail about the minimally invasive surgery part, how to go about it in the next talk by Dr. Somashekhar. But whatever we are talking about, categorization, etc., holds good for minimally invasive surgery as well, to ask me. So, the surgery where we have categorized them as most essential and urgent. But if you look at the action, surgery needs to be done as an emergency. Hence, we'll have to modify our SOPs to get RT-PCR because we don't have time to wait. This is where I'm coming down to. And category B, which is essential but semi-urgent, SOP needs to be strictly followed, which I will be elaborating now, and surgery needs to be done at the earliest. Category C, less essential but less urgent also. Again, SOP has to be strictly followed. The general principles I'm wantonly trying to place this is, I'm sure all the people who are working in major institutions or otherwise are following these principles, but there are some youngsters who may be sitting and watching me today. So for completion's sake, I'm saying this. The most important thing is reduce the risk to the patient, optimize the healthcare resource utilization, and reduce the risk to the healthcare professionals also. The measures for risk reduction, if you ask me, there are again two. Infection control measures like hand hygiene, social distancing, etc. has to be continued, and avoid overcrowding so that we can avoid limiting the number of visits, rescheduling follow-ups, etc. Coming to the SOP proper for cancer surgery per se, the most important one I feel is the healthcare professionals have been trained to protect themselves. This is the most important one I would say, because again and again I'm insisting that we have to protect ourselves to serve better. So we should be aware of what we are doing. And when I say we, I'm not talking about surgical staff alone. I mean everybody who is there in the hospital. Healthcare professional includes doctors, staff nurses, OT technicians, Group D who will come there to help us, everybody. And that's why we'll have to train them to protect themselves. And I prefer that a surgeon should be there in the team which is going to train them only to boost their morale. If their own surgeon is trying to come and talk to them, it will be better. But of course, the training can be done by other group also. They may be better off. But I said that the surgeon should be a part of it just to improve the morale. The universal screening of the patients at entry, complete history, multiple temperature checks, etc. should be done routinely. Taking to the next part, we have got two things. One, asymptomatic, another is symptomatic. Symptomatic people who have got history, who have got fever, who have got cough, and whom you think they have got what is called as ILI, the influenza-like illness, they will go through the PCR at least, and some of them are even suggesting chest CT, which we'll take it up during the discussion time. It comes to the asymptomatic, I suggested instead of doing RT-PCR for everybody, this is wantonly I put it, it is amenable for discussion, that serology IgM on day 1 and repeating on day 8 once it is made available is much better to do in a long run. We are in an endemic now, we are telling that we may do RT-PCR for everybody. That's what I understand most of the centers are doing. But that will not be the case in the long run. I am suggesting that IgM be done when it comes to the long run, something like HIV test which we used to do earlier. And then repeat it during the course of the time. Again, you can repeat it, and the cost of it also will not be more. And we are soon will be getting all this available. And in the discussion time, I will take it up. Is it available? Somebody may ask me. It is available, but the problem here is for reasons well known, the ICMR and the Ministry of Health, Family Welfare are not releasing that to everybody, and the vendors are ready, but they have not given permission for the vendors to take it, sell it to others. That is where the status is. And the staging workup for the cancer, including chest CT, I am trying to say, because the chest CT, most of the solid tumors may form a part here. We may become an additional point in this situation. If serology and CT scan are negative, we may take them for surgery. And this is a simple algorithm I have made. Asymptomatic, no risk factors. As I said, whatever I spoke, I put it there. IgM and CT scan test on admission. Everything can be contested in the discussion. I'll be happy if somebody opens up for a critically and analyze this. Nothing, as I said, has been tested here to say this is the only way to go. You are welcome to comment, criticize, and add. Negative, we'll go for surgery, workup for surgery, and I suggested repeat on 8th. Suppose if you have missed it on day 1, the IgM was not positive, once more you do it just before surgery and then take them for surgery. And anywhere the IgM and CT scan were positive, then they go to the considered as positive and then do an RT-PCR as a suspected case and take them as symptomatic, and RT-PCR is done and treat as a suspected case. One may be wondering, although this is not a point of discussion for today, but scientific background, I just want to say why I made IgM more important than the RT-PCR. Everybody has gone through this, a lot of discussions have gone on, I am aware of it, but still for completion, IgM in a asymptomatic would be better because the window period would have gone, who has got no risk, no ILI symptoms, there is no point in unnecessarily doing an RT-PCR at that point. And also, the RT-PCR was restricted. It has now just got opened up. In at least in Karnataka, I'm sure there are more than 30 centers who are doing RT-PCR, and they have allowed us to do. Otherwise, there is a problem. There are some small technical issues also there. The ICMR is insisting on they have to upload their portal the moment you do RT-PCR, wherever it is, whether it's a government sector or a private sector, in which they have mentioned certain indications. There is no indication for surgery has been mentioned, where we have to tick the last column called others, and we are doing it for those patients where if you at all you want to do RT-PCR. Otherwise, if RT-PCR becomes positive, the governmental agencies are making quite a lot of questioning, and the contact cases, etc., goes on, and that is another reason I try to avoid. I'm trying to suggest avoid RT-PCR and try to do an IgM. And coming to this side, on day 1 and day 7, if you take RT-PCR, will be okay. Afterwards, it starts declining, whereas IgM will start going up to 80% to 90% positive. And that's why I have suggested here. Coming to the SOP for surgery proper, the OT etiquette, the simple theory is consider everyone positive and take care of yourself. If they are asymptomatic, serology negative, chest CT negative, plan for surgery. I'm only repeating what I said here. In the usage of PPE, I'm very sure all of you have gone through enough and more, and I have been also in most of your groups watching you people doing from 10,500 to 350 rupees plus GST. This is the whole thing. I have seen enough and whole big group. But when we are doing surgery, when you are worried, I think covering your face with the simple gadgets are much more better than trying to wear too tight ones. At least I could not wear them for a long time. When I tried to use it, it was more one less suffocating, and second one is the visibility is becoming a problem. So I have to remove the goggles and work with my simple specs with a plastic cover, which is coming with a simple mask. That is what I use to cover my face. That worked well for me, and if something else which is suitable for you, you're welcome. The idea is to avoid getting exposure to your eyes, to your nose, to your mouth. That is the basic. I use N95 over which I use that mask. That mask has got a cover of the plastic also. It cost me around 100 rupees. It's a throwaway. But there are enough modifications. I have seen enough in different hospitals are going on with different ones. You're welcome during the discussion time how to go about it. Not only using and cut, and I also believe that cost cutting is also an issue in, of course, in a medical college like institutions and government institutions, we'll have to keep on thinking about the costing also. Coming to the OT again, anesthesia team alone will be asked to be present during induction. That's what we do. And once the induction is over, only after 15 minutes after the induction, the surgical nursing team enter. And before leaving the OT, increase air changes in the AHU and the keep door closed. The AHU usually turnings are around 20 times, means this we increase it to 25 times. And the cleaning personnel enter 30 minutes later with the prescribed PP. Intentionally, perioperatively, what we are planning to do, etc., I have avoided, because I am sure Dr. Somashekhar will be elaborating on that. Coming to the SOP for cancer surgery post-op, The OT etiquette again, I put it in an algorithmic way that the air handling unit air changes can be increased from 20 to 25. Coming to the post-op care, the post-operative patients to be monitored in designated post-op wards because I'm worried. But I was also told the opposite. There are people who wanted to go, within 2 days they leave. That's what I understand from so many people saying that they're afraid of staying in the hospital, so they want to go off at the earliest. Exactly opposite thinking. In the sense, they go off early hoping that they will not get infected. My problem here is, by any chance, if they are going to get in the post-op, most of our patients are anyway supra major, they will stay. In that during that period of time, if they develop ILI symptoms, influenza-like illness, we'll have to take care of them as suspected and go back, working up, seeing whether they are really positive, and take care of them properly. Last but the least question would be, should we do offer surgery for COVID-19 positive patients? Here is a patient who is positive, but he has got cancer also. Would you be doing surgery? At this point, I would personally say no. Based on that Wuhan University's experience, which I started quoting, where the mortality in the positive cases is very high, almost around 20%, which probably today in any elective case, we will not accept. And that is why I would suggest that in a COVID positive patients, better surgery be avoided at that point of time unless it is an emergency. And secondly, theoretically, when you know there is a positive case when you are going to handle, the chances of the healthcare professionals getting exposed is very high. The risk is higher. And based on these two, I would suggest that in a COVID-19 positive, you know it is positive. If it can be avoided, it should be avoided. And this, I just for the sake of completion, I put, I'm not going to really insist on this because I'm sure Dr. Somashekhar will elaborate on that because he's only going to talk about the practical aspects of how to handle in the OT and otherwise as far as minimal invasive concern. But most importantly, what I would, again and again, I'm telling this my last slide, please take care of yourself. Don't become over enthusiastic. On the other hand, we can't wait for such a long time for waiting for the COVID to disappear and then we start operating. That is also not possible. And hence, a balanced way of going ahead, taking care, protecting ourselves, as well as taking care of our patients should be the right approach, I feel. And that is how all this triaging as well as SOPs have been formed. Thank you very much.